This episode of EMS One-Stop is brought to you by Lexipol, the experts in policy, training, wellness support and grants assistance for first responders and government leaders. To learn more, visit lexipol.com, that's lexipol.com. Hello and welcome back to another edition of EMS One-Stop. I'm your host, Rob Lawrence, and this week we're going to go across the pond to the UK. We've also got a guest from here in the good old US, and we're just going to talk about thing one is just the continuing to have that discussion about the sad demise of ET3, and our UK friend and guest, Dr. Linda Dykes, can talk about, we'll actually pull back the curtain and show us what we could have won had we have persevered with it. And then we're going to go into a subject near and dear to all of our hearts, which is emergency management, and actually identify and celebrate the differences between UK and US emergency management techniques, and then go on to talk about an event that's coming up, a global event, dare I say, in early August. So without further ado, I'm looking at two of my very, very good friends from each side, each bank of the pond of the Atlantic. So Dr. Linda Dykes, give us your backstory.
Hello, thank you, Rob. Thanks for the invitation to join in today. My name's Linda. I'm a emergency physician. I'm also a GP, which I think you'd probably call a family physician in the United States. And I've spent about the past 7 years actually doing more work in acute community geriatrics than I have in the emergency department, although I do still do that. I've also got a background in training paramedics, initially with search and rescue in the days when I was young and a trauma junkie. These days I'm much more interested in keeping frail elderly people at home. And currently I'm actually supporting a team of advanced clinical practitioners who are advanced practitioners of varying professional backgrounds. I don't know what you call them in the USA. I'm just supposed to be joined by a dog, by the way. This is Zuri. Hi, Zuri. And I've got a mixture of paramedics, nurses, and therapists in that role. So it's exciting and lovely to be working directly alongside paramedics again on a daily basis.
Great. And also for everybody out there, Linda and I think Rom as well, in fact, will be appearing at EMS World Expo in New Orleans at the New Orleans Convention Center in September. And Linda, I think Linda and I actually deliver the international Roundup every year at Expo. And I think this is number 7, the 7th annual international Roundup with Rob and Linda. And when we get to talk about models of EMS around the world, and actually what I really enjoy, Linda, and I know that you do too, is we actually we select international members from the audience to talk about the issues, to talk about the successes, to talk about how it works for them in their country. And dare I say, we get great reviews by letting other people talk, and it's a great way to do it.
It's fantastic. I mean, I know that you do your filming on the elevator, but I also know that you usually have one ear pinned listening out for non-US accents. At which point we kind of pounce on people with accents from places other than the USA, and we kind of drag them along to the session and make them do the work. It's great. It's a lovely session. I really enjoy doing it, and it's different every year because obviously we have backup material available, but usually it just works as a conversation with a group of people in the room, and it's really fun. It's a great session.
Absolutely. So takeaway number 1, if you're coming to Expo, look up the International Roundup with myself and Linda. We're ignoring our other guest. Let's go back to the US shores, and a man that many people know, Rom, for that one person in the world that doesn't know who you are, give us an introduction.
Hello, my name is Rom Duckworth, and my day job is I am a shift commander, a fire captain, and the paramedic EMS coordinator for the Ridgefield Fire Department in Ridgefield, Connecticut. And we are a small paramedic transport fire rescue department about an hour outside of New York City. And on my days off, I teach EMS in different locations, including the UK when Linda can get me over there. And a member of the board of directors of the National Association of Emergency Medical Technicians.
Well, as I had a little preamble discussion with Linda, I'm going to do the same with you. And NAMT Lighthouse Leadership Project, going from strength to strength. I know you're involved in that. You're actually currently, I can see all the books behind you. Is this where the idea from the book club came along? But for those that, because of course we're going to start recruiting cohort number 3, I think very soon. So Give us a quick resume on the Lighthouse Leadership Project.
Sure. This was a vision of Jim Page, the one of the sort of the founders of modern EMS in the United States, and some of the old timers will know him as the person who set up the great show Emergency that inspired so many of us to get involved in the profession back in the day.
I'll translate in a second for you, Linda, by the way.
And so the Lighthouse Leadership Program was and is a way for us to reach out to people in EMS all across the country who don't have direct access to mentorship resources, and connect them with mentors like yourself, Rob, who can help answer questions for them. And it's networking, but not necessarily in, hey, get a leg up on your resume kind of a leg up, but in a, hey, I'm facing these difficult challenges. What do I do? What have you done? What resources? And their direct personal mentor and our network of mentors from NAEMT help them move the needle on some of the difficult questions that we're all facing. And sometimes when it's a challenge to do even that, at least offer a concerted ear. Oh my goodness, sorry.
I'm very excited about that particular mentorship program, and I think it's only fair that I mention that there's a number of them now starting off, which I think is an excellent thing. Not only do we have Lighthouse from NAMT, we have Next, or the Nexters, as they now call themselves, from the American Ambulance Association, and an email just went round the world looking for the next cohort of AAA's Next. And of course, women in EMS, women in emergency services, shall I say, have also a mentorship program. And some of my colleagues are mentors. And again, they're looking to recruit and attract mentees as well. So this is a great thing. And, long may it continue. Linda mentioned advanced practice paramedics and doing some of the GP or the family medicine type stuff, and obviously being an emergency physician. And I'm going to brag on you, Linda. For those that didn't know this, Linda was also the flight doc when Prince William was a search and rescue pilot back in the day. And so I'm sure if when you see her in New Orleans, you can ask her for a few of those stories. But Rom, we've lamented the demise of ET3. It's disappeared or disappearing. We know it's going. It was our chance to show that treatment in place, TILT, as I call it, treatment in lieu of transport, was a good thing. And of course, that would then secure payment. And again, this is probably alien to those that are listening in the UK, where healthcare is free at the point of delivery. Of course, trying to secure funding to do something that makes sense is something we had to prove via the ET3 program. The rug was pulled out from under us. And I know that to NAMT, because I was talking to President Susan Bailey only yesterday, in fact, that are putting together a letter to say, what the heck? I know a number of our attorneys, Page, Wolfberg and Worth, have written a what the heck letter. We're all writing what the heck letters. But, what do you think, man?
Well, I wasn't aware as much in depth about ET3 and some of the other legislation that's pending that would consider TIP and TAD, or treat in place or transport to alternate destinations. And then I got involved in the NAEMT advocacy committee. So I'm talking to senators and Congress people, telling them how important this is, knowing that we've got the backing basically of ET3 as of recently as a few months ago at the EMS on the Hill Day. And now ET3 has just been abruptly stopped early. And without that, it is impossible really to move forward with TIP and TAD. And it's just incredibly frustrating for something that we all know, and even have the numbers demonstrated, that is better for patients. It's better for ambulance services. It's saving everybody money. There's almost no downside to this whatsoever. So it's really baffling. And one of the things that's frustrating is that we're not seeing the why.
Right. And we're not inventing the wheel here, because the owner of the wheel is the other person on this call is over in the UK. And, you've heard Rom and I talk just now, and it just seems like now, it doesn't mean that we can't continue to do this community paramedicine lark, but it's going to be more difficult to sustain an income and funding to actually do it. And that's our US problem, Linda. But as I say, let's pull back the curtain. and let's see what we could have won. I mean, how's it going in the UK? And I know you're particularly deeply involved in some of this operation.
Yeah, so I was I've kind of been watching from afar the program of sort of officially trialing out the sort of discharge at sea and alternate destinations, etc. And I'm really sad to hear that's running into rocky ground now in terms of continuation, in terms of sustainable funding models in the US. So in the UK, there's actually major programs run out from NHS England and also in the other countries in the UK, so Wales, Scotland, Northern Ireland, to treat more people at home when it is appropriate to do so. Obviously, there are plenty of people for whom hospital evaluation or access to diagnostics is absolutely required. Nobody's arguing that, but there is a sort of substantial minority, which a substantial minority taken over the millions of people who call ambulances every year is a lot of people for whom transportation to hospital is not required. It's not clinically needed. I picked up a phrase that I use all the time that I picked up at EMS Expo, which is, sometimes we're actually using a stretched limo to deliver a pizza. And then you're on top of that, you're actually conveying the patient, for reasons that are bizarre and seem to be driven by nothing other than the fact that otherwise you won't get reimbursement for the work that's been done. Getting patients to hospital when they don't need it, or when worse, they are likely to be harmed by it, is a real consideration. The frail elderly, which is my particular area of interest these days, the risks of delirium, for example, from taking them to hospital when they just didn't need that. There was something wrong with them. They needed to be assessed and treated, but that could have been in their own home, and it could have been done either within primary care or within our system. Increasingly, we've got advanced paramedics who are master's level educated paramedic practitioners who will diagnose and treat in the medical model, and then hand over to services, either back to their own family doctor or over to services such as mine, which is called the urgent care response service when needed. I'm really sad to hear that the US is going to struggle to regain the traction that you seem to have been getting to make this happen. To give you an example, in the UK, at the Welsh Ambulance Service, which covers, I think, about 3.5 million people, by your standards, it's a very big ambulance service. By our standards, it's one of the smaller ones. They're actually, their direction of travel at the moment, they're calling it inverting the triangle, to try to stop, rather than the majority of patients being transported to an emergency department, they're trying to make it the minority and have most people treated in place. In order to do that, they're recruiting large numbers and training large numbers of paramedic practitioners, and have fully accepted the reality that EMS today in the UK is basically an urgent response service on wheels, with a small subsection, obviously it's still a sizable number of patients taken altogether, of the true life-threatening and immediately life-threatening emergencies. Lots of things are falling out of that. And we've also got the epidemiology changing, of course, as well, with the aging population, with the baby boomers coming through. Again, another phrase, I quote so many phrases at work that I picked up in America, but that as the baby boomers started to go to school, or reach school age, they had to have schools built for them. And then we're in a world now that wants to reduce the number of hospital beds. So what are we going to do in terms of their increasing healthcare needs? We know that in UK data, the bed utilization, hospital bed utilization per year goes up something like 24-fold between patients under 60 and patients over 85. And our first baby boomers are only just hitting 75 or so. So we've got a big problem. We've got there's still, it's, people have stopped talking about the demographic change so much, but we're in the middle of it, and we've got another 20 years to go.
As our good friend Ray Barashansky, parenthesis common spelling, would tell you, it's the silver tsunami, and it's here, and we have to be able to deal with that. So everybody out there, there's some food for thought there, that the UK are doing what we were hoping to do, and they're doing it very, very well. When we get to Expo, Linda, of course, we can have that discussion that is about graduate education, master's education, PhD education for the medics. Don't want to do that here today because we could spend hours doing that one. And so we'll park that. But before we sort of move on to part two, don't forget out there, everybody, you can catch this podcast or indeed this vlog, however you want to describe it, either on the podcast platform that you take your regular podcasts on, or indeed on YouTube. We're now on YouTube, so if you're listening to us, you can see us, and if you can see us, you can also listen to us. Don't forget, though, if you're listening to us on anything like Apple Podcasts, etc., pick up your phone, look at it. On there is a little check mark. If you check that, it means you've liked and you've subscribed. And so every time a new episode drops, you get notification that we're there and you can hear us. And so that's a very important part. Also, if you have any questions, please leave them in the comment section on the platform in which you are listening to this podcast or indeed watching this vlog on. There we go. It's very complicated these days, Linda and Rom, because we're on audio, we're on video, and I now have to comb my hair. So that's the thing. Now, moving on to the part two, and one of the reasons that we're together here today is that we are very shortly, next month, going to do an international major incident Super Saturday in the UK. And of course, what it did was it identified and helped sort of really brought home the fact that it's the same, but not the same. We are separated by a common language. And for those of you that have seen, again, Linda and I operate at Expo, Linda will say something and I then have to translate it into American. And it's a similar thing with emergency management and planning. We mean the same thing, but we don't say the same thing. So before we get into all of that, talk about what's coming up in August, Linda.
Yeah, so what's happening in August, on August 5th, where you can watch now or watch later, is that I've organised a webinar on major incidents and disasters. We've called it an international masterclass because what I've brought together is a sort of small panel of speakers just for this half-day virtual event. I suppose it's with the goal of all of them. I've asked to talk about what they've learned from major incidents themselves or yourselves, because of course both yourself and Romy are presenting at this, and what is there for somebody else to learn. Now, the reason I thought about this was that thankfully, true disasters and major incidents for most people who may be involved in them, either at the planning level or the delivery level or the operational level, thankfully for most people, they're not going to see enough or participate enough to become experts from their own experience alone. And nobody wants to be reinventing the wheel. There's learning from every single major incident or disaster of whatever ilk is out there. And so sharing that knowledge and passing that forward to those who will respond to the next one is incredibly important. And I wanted to just draw down, first of all, some of the things that my panel have learned themselves, and secondly, what they have learned that they need to pay forward and teach others, and what they wish that somebody had taught them. None of us know when the next major incident or disaster is going to be, but we do know that it's a day closer yesterday. It's a day closer today than it was yesterday, which is quite a sobering thought, really. We were a day closer to the next one, and we don't know what it will be.
So that's the premise of this, and of course, Rom, before we started recording, and I always tell people not to start talking before I hit the record button, because the best content comes out before we're recording. And so we're going to try and recreate the conversation we had before.
You can't tell me to stop talking, Rob. You can't.
No, I won't tell you this time. But I've had the absolute pleasure of being a gold commander, and in the UK the command structure is termed simply gold, silver, and bronze. So gold being the high level, and of course and then moving to the United States and becoming the unified commander within the National Incident Management System, within the emergency support functions. And so I've had that real chance to see both sides at work, and actually both sides within incidents at work as well. And so it's been fascinating, and realizing that we all have the same great intentions, we all have the same frustrations, and one of the things, and this is where Rob and I were talking about, the actions on the first crew arriving on the scene, and that first action being they're not there to actually start getting stuck into the casualty care. They're there to gather the situation, to send a situation report, to identify where other resources are going to come into, and actually how many resources you need, tempered against the fact that there are other people, bystanders, civilians, dare I say police officers, coming in trying to grab you and throw you into the scene to start casualty care. And so those those frustrations are the same, but obviously we just need to sort of unpack that and identify how each of us work and what those best practices are. And to that end, Rom, I think, having understood the UK system, and again, that concept of gold, silver, and bronze, and what happens to the first arriving crew, you've actually taken some best practice away already into the US, I think.
For me, yeah.
Yeah.
Some of the things that I had the opportunity to learn, again, thanks to Linda and being able to come over. One of the key things, both for being on a number of occasions, the paramedic who was looking at a major incident through a windshield, unexpected, first one there, pull up, there it is, got to do something. And as well as being at different command levels. And I'm not a big fan of acronyms necessarily. A lot of times they're used to make terrible questions on multiple choice exams, but there are a few that really do provide a fantastic framework. And the methane framework, the methane acronym as well, really does help those first people arriving explain to the other incoming units as well as the command structure, and help command structure be able to pass on that key information. Number one, M, that there's a major incident, E, the exact location, T, the type of incident, H, the hazards. Is there a collapse hazard, active shooter, explosion, etc.? A for access, where you can definitely go or you shouldn't go. N for the rough number of casualties, and E for the emergency services that need to be there, law enforcement, fire, rescue, whatever. And this always seems like a thing that, of course, I'm going to get there and I'm going to give an update. But what we know, and I'm telling you from having been that person, from having tried to get that information from the people who got there just before me, and from many, many after accident reports, it just doesn't happen the way that it should. And even when information gets passed off initially, does it get passed from EMS to police and fire so we're all on the same page? Does it get passed to the top level commanders so that exactly the right resources get dispatched to the right locations in a timely manner? It just doesn't happen. So this is one of the first things that I took back and we immediately began implementing in our own town and in our own department. We're still working on it, but we really think it helps.
And again, that situation where I always describe it, because of my previous life's background as the fog of war, that first 15 minutes on scene where pandemonium chaos is breaking out, having a formatted report that covers all of those points stops people like me in my old life, when I was the company commander or indeed the gold commander, screaming down the airwave radio or screaming down the company network to say, I need information. Where is it? Actually, you can very calmly and collectively give me the key things that help clear that fog. And I think that's going to be a great takeaway now. And we'll actually put that in the show notes as well, Rom, that acronym, because I think people could do with taking that away. But that first 15 minutes, though, is something that you're going to talk about and major on.
Absolutely. From being, like I say, we've all had sort of those calls over the years that happen a lot to you. And for me, for whatever reason, it's been involved both on the training side, because it's happened to me where I've been the first one there or one of the first people there at major incidents, which has led me to want to get better at it and participate in more training and more of it. So on both sides of it. And it really is going to be a talk about how to effectively establish and start to build the framework that needs to be there to support everyone when, as you say, a lot of pressure is being put on the first people there to just get in there, treat, and get them off scene. But we need to start to build that framework to maintain the forward movement of patients, and that's absolutely key. So we're going to talk about real, down-to-earth, boots on the ground practicality of how to wrap your head around what's going on, how to communicate what's going on, and then how to start making order out of chaos.
Now, there are major incidents and there are, major incidents. And we all saw the YouTube video of the Beirut port explosion. But we have the first responder from that as well, Linda.
Yeah, really exciting. So Dr. Chalky is coming to talk about, as he's an emergency physician who started his career in emergency services as an EMT with the Lebanese Red Cross. He was the commander of EMS services an emergency response that day for Lebanon, the whole of Lebanon, and the grain silos in the port blew up. Apparently, the fourth largest non-nuclear explosion in modern history. They had to deal with hundreds of people dead, thousands of people injured in the middle of the COVID pandemic. And then to make matters worse, their city hospitals, who would normally be the response hospitals for an incident within Beirut, were damaged by the explosion themselves. So, wrapped around the sort of, the disaster of COVID was this enormous explosion in an urban area. Then it took out the functionality of two of the hospitals, which then had to be evacuated. It was kind of, incident inside disaster. And I know from meeting Shawkey again in America that the Lebanon used the UK's JESSOP protocol, which is the Joint Emergency Services Incident Protocol, which I'm hoping you're just about to jump in, Rob, and tell me what the US equivalent is again.
So it would be NIMS, the National Incident Management System. And again, that really came about after 9/11. And of course, when we look at the New York After Action report, the first battle, as always, with every major incident was communication. And there was a massive failure of the ability to communicate. Different radio networks, different protocols, different acronyms, different 10 codes and all this other stuff, 10-4 if you're listening. And so that really was the catalyst that created, that particular system. And so, but it took that level of, tragedy to cause it to happen. But, and I have to say, and I'm going to be, I'm not being disingenuous to our police colleagues, but it took them a while to get on board with this. And I'm delighted, through certainly my experience in Virginia and my experience in California, that we're getting there now. Firefighters, very, very good at this, thanks to wildland firefighting having to be super uber coordinated because you can't lose a section of firefighters if the wind changes, et cetera, et cetera. EMS got on board fairly quickly. Police are now with us, and I think things are. You feel free to agree or disagree, Rob. I think things are feeling joint and unified now.
Yeah, I think so. And one of the points that I always try to make when I'm involved in training on unified command is it's not who's most important. It's what needs to be done first. And that's what we focus on. And I think that really helps people. And I agree with you. We're getting better at it.
Yeah. And actually, I have to, go back to my UK days where in Suffolk, a county is a state. So just to sort of do that translation for us all between UK, US, so I led a county strategic coordinating group. And I shared it with actually the deputy chief constable, the deputy chief of the county police. And they were normally it's the purview of the police to run this thing, but they're like, half of this stuff we do is a medical issue or an emergency medical response. Why am I, as the chief cop in charge? You should be doing this. And actually, and it's right, because of course then your thought processes are different. But actually, we're working in a joint environment. And actually, if you look at the poster that Linda very kindly put up on social media, one of my don't even think of the word here. One of my proudest moments was to be have a photograph of all the the deputy fire chief, deputy police chief, me, the emergency managers. When that was the tight knit group that did many things, including H1N1. When the Bernard Matthews turkey factory, if you're listening in the UK, in Norfolk, came down with a massive dose of bird flu, and that caused all sorts of shenanigans. And it was a clinical issue. We had to ensure that, and therefore the deputy chief constable went, "Okay, Rob, you're on deck. It's yours." And then it is what it is, and so that's key. But Linda, I mean, what else are we going to talk about on the day? We've got a 4-hour super session. And by the way, if you can watch it live, but it's going to be in the daytime in the UK, and it's going to be for you night shifters in the US, by the way. So that's the first thing. But also it's on demand. And thanks to our friends at Prodigy for the US listeners, we're going to provide CE for our US audience as well. So that's cool. But who else is coming up, Linda?
Oh, yeah. So we're starting off with Shawkey talking about the Beirut port explosion, which is just of interest to anybody in itself. that brings to the what I've asked him to pull out the things that he noticed using the UK system, because I had put him in touch with Stephen Groves. Now, Stephen Groves is an emergency medicine nurse by background. I met him when he was an EM manager, when I was a slightly feral registrar or resident to you guys. And Stephen is now the head of EPRR, so emergency preparedness, resilience, and what's the other one? For NHS England. So he is working at government level in the emergency responsiveness and preparedness sector. And I had put Shorky in touch with him to talk about the learning that was available to the UK from the Beirut port explosion. I think Stephen's probably going to be talking about quite a wide variety of things, and I suspect we'll have a very interesting Q&A on that one, because he was also had to sort of procure PPE for the UK at the start of the COVID pandemic, which was a real problem here actually. And I'm sure
don't get us going on the availability of crappy PPE in the US either. So that could be another hour's podcast, right?
I suspect he'll touch on the learning from the Manchester bombing inquiry, which is an important one. And after him, we have got Phil Coburn, who is emergency physician pre-hospital, physician flight physician in the UK. Now, Phil is going to talk about the 10-second triage. So, in the UK systems for a number of decades, we've used a two-step process for triaging casualties at mass casualty incidents, the SIV and the SORT. They have been scrapped based on sort of practical feedback and replaced by a new rapid triage system, and including the fantastic 10-second triage. Phil did tell me he wanted to call it the quick and dirty triage, but the NHS England wouldn't let him. And he's actually going to talk about the evidence behind that, the reasons for the change, the human factors and simulation that've gone into actually using it. And so that should be another really useful practical talk, first of all, for any UK viewers who haven't yet been introduced to 10-second triage, and secondly, just in the kind of this learning from previous incidents, what can we do differently? Something we've had for 20-30 years, actually it's maybe time it is replaced. And then the final speaker is of course our own Rom, who's right here on this call, who has we would have, am I allowed to say a rude word on these podcasts, or is that completely banned? Okay.
This, ladies and gentlemen, this is what I do at conferences. I actually have to watch Linda's potty mouth, and you can't swear on this show. No, okay. no. And we don't edit this either, Linda. So
okay.
No.
So whatever your word is for somebody who seems to have a disproportionate exposure to gnarly jobs, so we would call it a beep magnet.
Okay, I think the listeners got that. Yeah, that's enough. Move on.
Okay, that's cool. So Rom, who has experienced a number of incidents in his career, more than the average UK paramedic certainly would have been exposed to, and obviously Rom is such a gifted educator. I really wanted to hear his thoughts and to share what he has learned, what he wished he'd known at the various incidents he's attended or responded to in various guises and at various levels, and then what he makes a point of sort of teaching forward to others who may be following in the footsteps.
Well, actually, my last question to both of you was actually going to be based on what you just said, Linda. And so, in any emergency situation you've ever been involved with before, what's the one biggest takeaway? And before I ask you to answer that, I have this theory. There's lessons learned. We talk about lessons learned, and there's lessons identified, right? And so we do all these after-action reviews. We come up with these big checklists of things we should take note of. That's the lesson identified. It's not necessarily a lesson learned, right? Because we have to create a policy, create drill, practice it, rehearse it, etc. So what's your biggest lesson learned from your experience?
I suppose for me, luckily, I've never actually been involved in a major disaster response. I've been very lucky in my emergency physician career not to have to. What I can say is if I know that resus is about to kick off and I've got a standby call from an ambulance crew, what I have learned is go for a potty stop first and ideally a glass of water, because it may be some time before you can do anything else. And you will not be able to concentrate if your bladder is full.
I'm just going to jump in with a corollary to that during the pandemic, as we put our folk into their Tyvek suits, we had to change the SOP from number one, put suit on, to number one, pee first. So yes, there is that. Romy, what's
Human
your
thought that was
factors,
the
we're
first
all
P in
limited by our
PPE.
physiology.
Oh, that would be triple PE.
Exactly. For me, when it comes to major incidents that involve a lot of patients, that sort of have 1.5 lessons, that there's so many things you could say, but the overall focus is on the forward movement of patients, so that everything that you're doing when you're focusing on it, it's on maintaining that forward movement of patients. But what has to go into that with the structure is that the boots on the ground people don't work for the command structure. The command structure only exists to support the boots on the ground. And as soon as both parties understand that effectively, that the command structure is only there to support the boots on the ground, they start making more effective decisions to maintain that forward movement of patients. And it helps bring order out of chaos, and it helps everybody work together to save lives and reduce harm.
I'm going to throw one in because I'm the host. And during the 7/7 bombings, what we quickly realized was, of course, London hospitals were getting prepared to fill up. And of course, in order to fill up, you have to empty. And so we now need two complete ambulance services, one to be the emergency service, and then another one to evacuate the back door of those hospitals to create capacity. And that actually created a ripple effect in and around London to about 200 miles, and in my area we had the very specialist hospitals, Addenbrooke's, and in my particular area, all of a sudden we're getting phone calls from every specialist saying, I need to get these patients out. Where to? Don't care, because we're getting prepared to receive patients in. And that created a logistic nightmare that I have to say hadn't been thought of before. And so whilst the incident may be in location A, locations B, C, D, and E are also going to feel the effect. There we go. That's my lesson identified and lesson learned. Anyway, that's it. So how can we follow you guys? Linda, you are the Twitterati Queen of England. And so who are you and where are you on Twitter?
So you can easily find me on Twitter. It's at Dr. Linda Dykes. That's Linda with an I, Dykes with a Y. It'd be lovely to see you on there. So I'm very easy to find.
Rom, I love how you can introduce this Twitter handle. Ready? Go.
My parents were lovely enough to name me Rom Duckworth. So any Google search of Rom Duckworth or Rom Duck will get you to an email or a website or a Twitter handle. I am at Rom Duck on Twitter as well. Not as prolific as Linda, but I'm easy to find. I'm a Google search away.
Excellent. I love that when you tell that. I can listen to that every time. And don't forget, you can follow me on Twitter at UKRobL1, or go over and find us all, I think, on LinkedIn as well. So we're there. So that's another edition of EMS One-Stop. I'd like to thank my guests and my good friends, Dr. Linda Dykes and Rom Duckworth. Google him. His parents named him such so that you could Google him. And we're going to see you next week. Don't forget, as I said, Linda and I and Rom will be at Expo. So if you want to come and see us and chat about all matters international, do that. We're going to put the links to the upcoming 5th of August event in the show notes as well. And there's tons of social media on that. But for the moment, don't forget, make sure you like and subscribe. You can catch us on all the regular podcast platforms. And also you can see us, if you're not looking at us now, on YouTube. So this has been another edition of One Stop. They were Linda Dykes and Rom Duckworth. I've been Rob Lawrence, and until next time, bye for now.